Hi, everyone. Thank you for joining us today. We'll be starting very shortly. We're just going to give people a little bit more time to join. We'll be back in a moment. Good afternoon, everyone. My name is Jessie Klein, physical therapist and pelvic health program director at Spear Physical and Occupational Therapy. I'd like to welcome back those of you who have attended one of our webinars, as well as welcome those who are joining us for the first time. We appreciate you taking time out of your busy day to learn with us. For those of you who don't know who we are, Spear is a private outpatient practice that has been around for over 20 years with currently 21 locations all over the New York City area. We have successfully continued to offer in-person care through the COVID-19 pandemic, as well as launched Spear Live for those who are looking to stay and receive care using our telehealth platform from the comfort of your own home. In our clinics, we are strategically going above and beyond the CDC guidelines to ensure the safety and well-being of everyone. You can find more detailed information on those safety measures by visiting our website at spearcenter.com. We are here for you in whichever way makes you feel most comfortable. If you are looking for individualized care, either in the clinic or through telehealth, please reach out to us at your convenience and we'll get you set up for an appointment right away. We're excited to be with you today to discuss incontinence and how it relates to pelvic health. We will be discussing pelvic anatomy, bladder and bowel norms and habits, as well as treatment methods to address and improve these conditions. As a part of our session today, we will be talking through and demonstrating some of these exercises, and we welcome you to follow along and practice with us as you feel comfortable. Please note, if you are experiencing any pain while performing any of these exercises, or you feel unsteady or unsafe to perform them on your own, please stop and reach out to us directly so we can help you. As you can see, we are coming to you live from our own homes. And although we do not anticipate any technical issues today, please be patient with us should any arise as we navigate through this technology. Housekeeping. Throughout the webinar, we want to hear from you. If you have any questions, please feel free to let us know your thoughts in the Q&A feature. To find where that is, please take a moment to hover your mouse over the bottom of your screen and you will see a Q&A option pop up. That is where you will put questions, and we will do our best to address as many of them as we can during the webinar. It is best to put questions in the Q&A. If you put questions in the chat feature, we will likely be unable to reach them during the webinar. For those of you who are watching through YouTube Live, we are monitoring the comments section there as well, so please feel free to type your questions in. Lastly, there will be times where multiple panelists will be on the screen. For the best viewing experience, please select Gallery View at the top right corner of your Zoom screen, so you'll be able to see multiple panelists at one time. If you're having any visual issues, it may be the Gallery View as well, so make sure that you select Gallery View at the top right. So let's talk more about our goals for the day and what we will be covering. So first, we're going to review pelvic anatomy. We're going to explain different types of incontinence and bladder and bowel norms, as well as answer your questions live. Before we get started, I'd like to introduce our team of panelists. We're going to welcome everyone onto the screen now. Our presenters today are Rebecca Arkin and Marianna DeCaro. Rebecca is an occupational therapist and pelvic health specialist at our Murray Hill office. Hey, Rebecca.
Hello.
Marianna is a physical therapist and pelvic health specialist from our Park Slope location. Hey, Marianna.
Hey, guys.
And lastly, we have Tom Barsha, who is also a physical therapist and our clinical director at our Midtown West 44th Street office. He will be helping us with answering your questions in the Q&A today. Hey, Tom.
Hey, everyone.
Just as a reminder to everyone, it's best to be in gallery view so that you can see everyone at the same time. If you've done that, you should be able to see all four of us right now. All right, let's get started. Rebecca, Tom, and I are going to say goodbye for now. Marianna will let you take it away with some information on anatomy.
Thanks, Jessie. So we're first going to start off with a poll. Have you attended previous pelvic floor webinars? Yes or no? I'm going to give it a little bit. Type in, click yes or no. I'm really excited for this webinar today and answering your questions at the end. So please put your questions in the Q&A section. And we'll give it a little bit more time. I'm so excited to see so many people participating in today's live webinar. And again, this is recorded too. If you are unable, if you want to refer someone to see and watch and learn about the pelvic floor in our incontinence webinar. Alrighty. So thank you for answering that. So we've had a lot of people who haven't, but thanks for joining in and some who have. So we're going to get started on the anatomy. So let's talk a little bit about the anatomy of the pelvic floor. There are 3 layers of muscle to the pelvic floor, and the functions of the pelvic floor are bowel, bladder, sexual, and support. So I'm going to go over a little bit of the anatomy of vulvar owners. So that's going to be more on your left side of the screen. So that first layer of muscle is your superficial layer, that first layer of contact. And these muscles, some of them are important when it comes to continence. And that second layer of muscle is really important for continence. It's the urogenital layer. And that third layer of muscle, where our larger pelvic floor muscles are called the levator ani. And all 3 of those layers make up the pelvic floor. And I'm just going to bring Rebecca on to talk us through a little bit of the anatomy of penis owners.
So for those who are penis owners, their anatomy is actually very similar to vulva owners. For the muscles, the only difference is that in layer 2, they do not have a deep transverse perineal or external urethral sphincter. And now Marianna is going to take you through some more information.
Thanks, Rebecca. So now let's go on like what's normal when we normally go to the bathroom, which is continence. So continence is the voluntary control that we have over our bladder and bowel function. So it requires an intact nervous system, both like central and peripheral, and relies on intact cognitive function. So continence requires the ability of the bladder to expand and contract. We need sensory awareness of when the bladder is full and the ability to wait until we're on the toilet to void. And so with that, we have the bladder reflex. So that bladder reflex, what happens when we voluntarily void? It's when you have that urge to go to the bathroom, you're seated on the toilet, those pelvic floor muscles have to relax so that muscle in the bladder, called the detrusor muscle, can contract and allow for urination. And so this is really important when we talk about muscle tone. So with muscle tone, like normal tone is like we're sitting up, we're standing, that normal posture, that muscle tone that has us there. But there are two tones when there is dysfunction. And this is commonly seen when there's any like pelvic floor disorder. So there are hypertonic and hypotonic muscles. So a hypertonic muscle of the pelvic floor means that those muscles are overactive or there's too much tone. So there's a misconception that an overactive muscle is a strong muscle. But let me give you like the example of the bicep here. So if a muscle is too tight, there's less range for that muscle to strengthen instead of going through its whole range. And so now the opposite of that is a hypotonic muscle, which means that that muscle has less tone, it's underperforming, it's weak or underactive. And hypotonicity is really common when it comes to incontinence of the bowel and bladder. And so your pelvic therapist might work on pelvic floor contractions known as Kegels to strengthen the pelvic floor if this is an issue with hypotonicity. And now I'm going to introduce and invite Rebecca back on.
So now we are going to go to our second poll. How many women over the age of 18 experience involuntary leakage? A, 1 in 10, B, 1 in 5, C, 1 in 4, or D, 1 in 8? This answer usually surprises people. We're just waiting on the results. So the most common answer was 1 in 5. The answer is actually 1 in 4. So about 25% of individuals over the age of 18 experience involuntary urinary leakage. So now I'm going to go into some bladder and bowel norms and some bad habits that we picked up on. So the first norm is that it's normal to have 5 to 8 voids in a 24-hour period. And so this translates from anywhere from voiding every 2 to 4 hours. For bowel movements, it's normal to have one as few as every 3 days to as frequently as 3 times a day. No jicking. So this is just in case peeing. An example of this is you're about to leave your home, you're going to go to the grocery store 30 minutes away and you pee, you're home just in case. Other bad habits are squatting or hovering over the toilet, doing a pelvic floor contraction, sometimes called a Kegel, while urinating, straining or pushing your pee to come out faster, avoiding fluids so that you either leak less or that you void less frequently, and holding urine. Other signs of dysfunction can be hesitancy to start your flow, stop and go flow, spraying, incomplete feeling after voiding, the immediate feel that you need to void again, and pain before, during, or after a void. And now I'm going to talk about incontinence. So this is the lack of voluntary control of bowel and bladder function. This is when urine leaks out before you can get to the bathroom. This could be a few drops when you sneeze or you laugh. It could also just be a complete void that you couldn't make it to the bathroom. Urine loss can also occur during sexual activity, and it's more common than you think. Like we said before, it occurs in 25% of young women, 44 to 57% of middle-aged women. And now I'm going to go through different types of incontinence. So the first one is urge incontinence. And so this is when leaking occurs after a strong and sudden need to urinate. So you're sitting down and all of a sudden you just have to go. It can occur when you don't expect it, such as sleeping, after you drink water, when you are washing the dishes and you hear the sound of water. The other type of incontinence is stress incontinence. So this one's very common. It happens when you sneeze, you laugh, you cough, you're picking up heavy items, you're at the gym, or any other movement that can put a lot of pressure onto your bladder and pelvic floor. This is the most common type. It often occurs from physical changes from pregnancy, childbirth, menopause, and it can also occur just for a variety of reasons. There's also mixed incontinence. This is two or more types of incontinence. Often we see a combination of stress and urge incontinence. Fecal incontinence is the lack of control of stool, and functional incontinence describes people who leak on their way to the bathroom because they physically can't make it there on time, or they're having difficulty unbuttoning their pants. So this is kind of more related to other physical impairments that are less of pelvic floor and more could be your hands or your ability to walk quickly. And now we're going to go over some treatment stretches and exercises, and I'm going to have Marianna come back on to demo some of these.
Thanks, Rebecca. So we're first going to go over a diaphragmatic breathing exercise. So I'm going to roll back. Everyone can join if they want. We're going to place their hands on their lower abdomen here. And so when we inhale low into our hands should expand. You might feel a drop in the pelvic floor, like closer into your seat. And when you exhale, the rib cage goes back down and the pelvic floor can just go back to resting position. So we're going to try that a few times. You can do this in and out through the nose. So we're going to inhale through the nose, breathe into those lower hands and abdomen, take up all that space, that 360 space there. And as we exhale, we're just letting the abdomen drop back to normal. So this might be a common exercise to couple with a pelvic floor contraction, which is known as a Kegel. You might be doing that contraction as we exhale. So this is an exercise you can do, 10 reps several times a day. It's really nice if like you're working from home, getting out of your seat, or being in your seat and taking a few of those deep diaphragmatic breaths. Going into a little bit more of strengthening, we're going to be laying on our backs, and we're going to go into some glute bridges. So hips are feet are about hips width apart here. We're going to be engaging our butt, mini tuck of the pelvis, just so it's in neutral. We're going to squeeze our butt and lift a few inches off of the table and lower it down with control. This may also be coupled with a pelvic floor contraction, but right now we're just strengthening the glutes surrounding the pelvic floor. Doing about 3 to 10 reps of this daily will help with that strength. Now I'm going to have everyone lay on their side. And this exercise is a clamshell. So laying on our side, knees are bent about 90 degrees. Our heels are in line with our hips here. So we're targeting this glute med muscle, which is really important with gait as we're walking, and it also couples with our glutes, supporting our pelvic floor. So keeping our hips forward, we're going to spin open the top knee, and then with control, lowering back down. Heels are together. You can lay directly on our side. This is a nice exercise to turn into a progression, either with a band, doing it in a side plank, or in standing. And you should be feeling that in the back of your hip here. If you're feeling it too much in the front, make sure you roll those hips forward a little bit more. And again, you would do this 3 sets of 10 about on each side. And these are safe to do daily. Rebecca's going to take us through a few of our other exercises.
Thank you for that wonderful demo. I'm going to take you through doing a squat. So you're going to stand about hips width distance apart. You're going to bring your butt back. And as you come up, you want to press through your heels and squeeze your butt up. So just like this. And then after we do any type of hip strengthening, pelvic floor strengthening, we always want to do a few stretches. So now I'm going to show you happy baby. So you'll lay on your back and you're going to grab your ankles. And if the ankles is too difficult, you can also grab onto behind your knees. And you just want to take a few big, deep diaphragmatic breaths that Marianna showed you and focus on breathing into kind of like your pelvic floor area. And then the next stretch I'm going to show you, you're going to be laying on your side. Your knees can be slightly bent. You're going to bring both arms forward in front of you. You're going to take a deep inhale, open up. This one's called open book because it looks like you're opening the book. Exhale, close the book. And you can do a few of these. So inhale, exhale as you close. And so now I'm going to bring Jessie back on the screen so we can get to some questions.
All right, that was really great information. Thank you guys. We saved lots of time for questions and we actually had a lot of questions come in. So let's get the ball rolling. So the first question that we had is it normal to leak at the gym or with running?
So while this is very common, I would not call this normal. When you're at the gym, you can either be like lifting heavy items like weights, a weighted ball, or running. This increases abdominal pressure onto your pelvic floor. So it's a closed cavity. So as you lift something, you put pressure, and if your pelvic floor isn't strong enough, that can cause a leak. And so it's common, not normal. It's something that if it does occur to you, definitely go see a pelvic floor therapist.
Got it. Nice. Can you tell us what a Kegel is?
Yeah, so I mentioned this a few times before. So that's that pelvic floor muscle contraction. So think about that anatomy that we talked about a little bit earlier, consisting of all of those 3 layers of muscle. So when we engage our pelvic floor, I want you to think of those pelvic floor muscles coming together and then going up. And so with that, we can hold a pelvic floor contraction, let's say for about 10 seconds. We can also do really quick contractions of those pelvic floor, like fully contracting and fully relaxing. So a Kegel is something, that we would give more for pelvic floor weakness. So this is not necessarily ideal or recommended, let's say if the muscles are too tight.
All right, just looking for some more questions here. Oh, this is a good one. How does constipation relate to leaking?
So the bladder and bowel live very, very closely together. So inside of your hip, you have your bladder and bowel, and if you're female, you also have your uterus. And so if your bowel is full of stool, it's going to start pressing into your bladder, and that can increase that sense of urgency, and it can also even impact and cause you to leak.
Okay. And just looking through our Q&A here. So does caffeine affect the need to pee more often, and does it affect incontinence?
That's a really good question. So there are a lot of irritants to the bladder, but some of those common ones can be something like caffeine or carbonated drinks or something that's like really acidic. So making sure that, you're balancing that out with hydrating with water, with those clear fluids there, because that could really affect your urgency or your frequency or any other type of incontinence that's going
on. Okay, another one here. This is a little more of like a specific symptoms, but I'm sure a lot of people in the audience are experiencing this as well. It says, I wake up about every 2 to 3 hours at night to pee. My doctor said everything is okay. It seems like maybe a slight overactive bladder, but is there anything that this person can do so that they're not waking up so often at night?
Yeah, so I would definitely see if you can get in with a pelvic floor therapist. But in the meantime, something that you can do is think about how much fluids you're taking in, maybe before you go to sleep. Doing some of these exercises and stretches, something is maybe overactive. We kind of want to calm down and stretch and down train, possibly. So some of these stretches that Rebecca specifically went over in the diaphragmatic breathing, trying that before bed may help with the decrease in frequency at night.
Got it. Our next one here is asking about the key and lock incontinence. So they want to know a little bit more about that when you have, and just for a little background here, the key and lock incontinence, when you get to the door and feeling you have that extreme urge, but can you explain maybe a little bit more about that and maybe some strategies for people who have the key and lock incontinence?
So with that, with the key and lock, so going back a little bit more to like what is normal. So there's that bowel and bladder reflex loop, right? So there's somewhat of a break in there. There's been a bad habit that's been created maybe over time subconsciously that you're not necessarily aware of. And when you're doing that key and lock, like there's that urgency that is immediately coming that I need to go to the bathroom. So goals and tips to try to avoid that is you want to kind of distract. You want to gain more control over the pelvic floor and over your bladder habits. And doing that, you can be distracting yourself maybe by like looking at your phone, taking a deep breath, positive affirmations, maybe doing a few Kegels if it's more of like a weakness issue to distract to then get you to the bathroom.
Yeah, it's funny. It's, counterintuitive that you're supposed to actually go more slowly on your way to the bathroom, even though it feels like such an urge or rush to get there. But it really works,
Really does.
Okay, let's see. Rebecca, the open book exercise, would you mind just coordinating the breathing again for us?
Yes, so when you're laying on your side, as you open up that book, you want to take a deep inhale. And as you come to close the book, you're going to exhale on the close.
Got it. Thank you. Let's see. Oh, this is an interesting question. Why is incontinence worse before and during menstruating?
So it's been found a little bit more that like in that second half of your menstrual cycle that can increase. It sometimes can be more related to hormone levels. It can also depend on your menstrual cycle, like when you do have your period as well. I think Rebecca, you were going to mention something there.
You also have increase in water retention, and often frequency can also get worse around your period.
Another question here. How do you know if your muscles are too tight or too loose?
That's a really good question. I definitely would get checked out by a pelvic health therapist to identify if it's a tightness issue or if it's a weakness issue. That's something hard to sometimes identify on your own if you're someone who maybe has like maybe higher stress levels or more anxious or finds they're gripping or tight, like tightening in between their legs, having a hard time releasing. That can maybe be an indicator that the pelvic floor muscles are a little bit too tight compared to being hypotonic.
Could you go over the bad habits to avoid one more time, or maybe a little slower in what they are?
Yeah, for sure. So the biggest one that I see is just in case peeing. So especially in New York City, you're about to get on the subway for 30 minutes and you go before you leave the home, you get to wherever you arrive, you're like, I have an hour meeting, I'm going to pee. These are bad for the bladder. It kind of makes your bladder think that this is normal, and you get into these habits where you're avoiding more than every 2 to 4 hours. Another big one that I see is squatting on the toilet, especially in public places. When you're squatting, your pelvic floor is contracting, and so the detrusor, the muscle around your bladder, can't effectively do its job. So either lay down toilet paper, wipe, do what you gotta do, but get your butt on there. Other common habits that I see are pushing. So you're in a rush, you have a meeting in 5 minutes, you're just gonna squeeze all of it out of your bladder. It's also not good. Holding in urine for long periods of time is not good. Avoiding fluids because you either are nervous that you're going to leak or that you're peeing too much, so you stop drinking water, is also a bad habit. Anything else, Marianna, do you think?
I think you've mentioned it all for sure.
All right, on to our next question. Can pelvic organ prolapse or bowel prolapse, I guess rectal prolapse, cause incontinence? If so, can surgery cure it?
Can definitely lead to incontinence. Surgery can be an answer. There's different grades of a prolapse, whether it's the uterus or the rectum or the urethra falling into the vaginal cavity. I would definitely, there's certain tiers before the step of surgery. There are tools called pessaries. There's pelvic floor strengthening. There are garments that you can wear. There's a lot of exercises and strengthening that you can do. But once we kind of know the level of severity of the prolapse, the best course of action will be made with you.
Great. The next one is also another kind of more case specific, but I think maybe relevant for a lot of people in the audience. I had a hysterectomy. Oh, just lost my place. Here we go. And an anterior and posterior repair 2 years ago. I feel like incontinence has gotten worse since the procedure. Is this common after these procedures?
It's definitely common, and often people still need to go to pelvic floor therapy because, like any other surgery, you go to rehab after if you get surgery on your shoulder, your knee. So learning how to kind of coordinate the muscles so that they're able to contract, relax, and just stay at the normal tone is important. And often, we like to do a multi-approach. So even if we're getting surgery, usually we work with the doctors to see what the best plan of care is.
Awesome. We did get another question about at what point is surgery indicated, and if so, what is involved in the surgery? I think a little bit of this is beyond our scope, but maybe you can talk about, at what point surgery might be something to consider.
Yeah, so there's different grades of a prolapse going from 0 to 4, and that's really just kind of is where how the descent of the organ is coming in or out of the vagina, and how the sustainability, how it affects your daily life is a really big factor, whether surgery is a good option for you. Like Jessie says, the details of a surgery is beyond our scope of practice. So I definitely recommend talking to your gynecologist about this, whoever your provider that you're considering doing this. But to know that grade, we do recommend going into to see a pelvic floor therapist or seeing your provider.
Let's see. Oh, this is a good one. If you void 19 times a day, where does all of the pee come from?
So you actually are peeing less. So a typical void, if you were to count in Mississippi seconds, should be anywhere from 8 Mississippi seconds to 15 Mississippi seconds. If you're voiding 19 times a day, it's very likely that your void is probably like 3 Mississippi seconds. So instead of being efficient, your bladder is just going all the time.
All right, let's see. We're getting more questions, so my screen keeps shifting a bit. Okay, this is interesting. Why do I pee more at night than during the day?
So some of that can be due to, like, just thinking at the end of the day, the fatigue of those muscles at the end of the day going more frequently. It's also a combination of what you were doing that day, how much you were drinking, what you ate, any type of irritants that may have been going on. And then a lot of the time, there are like these habits. So sometimes some people pee more in the morning, like before 12 o'clock. They're going 10 times a day. 10 times before 12. So this can also be something that can happen before going to bed, making sure you don't want to go in the middle of the night, and making sure you empty your bladder before.
Our next one is waiting to pee a way to train yourself not to go so often?
So yes, but usually we do gradual increments. So if you're someone who right now is peeing every 30 minutes, we use distraction techniques and urge techniques, but we only increase that by 15 minutes. And so the idea is that if you're going every 30 minutes, we can prolong it to 45 minutes, and then your body will naturally get adjusted to going in these 45 increments. And then from there, we'll add it on another 15, and we'll get you to 60, and eventually you'll get to the 2 to 4 hours. I would not suggest going from every 30 minutes to every kind of 2 to 4 hours. It's too much for your body.
Great. Our next question is, does using a squatty potty help to void your full bowel movement?
Yeah, the squatty potty is really wonderful to do. You could even makeshift it with some books or some stools that you have at home. It's just getting your knees higher than your hips. And it allows like direct access for like the rectum to fully relieve yourself with less pushing and straining.
Yeah, you can also use a stool, or, you know, it doesn't have to be the squatty potty specifically, although it is great. All right, how much should I be drinking? I drink 8 glasses of water a day and find I urinate about every hour or so. Is that normal?
So typically the standard is half of your body weight in ounces. So if you were 120 pounds, you would drink 60 ounces of water. And if you're going every hour, that's likely too frequent. And if you want to change that, you definitely could.
All right, our next one is, why is this, I'm guessing incontinence, worse after menopause? Should a woman expect to have more problems after? Okay, these are 2 separate questions. So why is it worse after menopause?
So a lot of it has to do with the hormones that, you know, decrease in estrogen. Estrogen's a really amazing hormone for like skin and muscle integrity, and like weakness that comes also with that shift as well.
All right, let's see what we got next. Okay, sometimes when I go and sit for another minute or 2, more comes out, close to the same amount. What's going on?
So sometimes it, you know, with incontinence, there can be difficulty completing, the same way as like difficulty initiating. So doing that, like stand up and pee, it's not having enough time to fully complete your bladder. So you can even do some of these techniques that we talked about, like with the breathing, really trying to relax the pelvic floor to allow for the bladder to contract and release urine, to allow for that void. So you can always give it a few more seconds, take a few more deep breaths, even if you need to stand up, kind of shake, and then come right back down. So then train yourself that you don't need to go back to the bathroom like 5 minutes later, and that you can complete it all in one void.
Great. All right, sorry about that. My Q&A keeps refreshing because we're getting more questions.
Yay!
The exercises that you guys showed, is twice a week enough to do?
I recommend 3 to 4 times a week, but it depends on each person. Marianna, what do you usually recommend?
So from just like a PT standpoint, doing these exercises every day is the best way to retrain. Repetition is the best way to retrain. When it comes to the pelvic floor, there are so many systems involved, such as like the neuromuscular system and the nervous system, and that repetition, sometimes if it's like the breathing, we would do that, you know, maybe 2 or 3 times a day. And then once that's like really internalized, we'll maybe break it down to maybe once a day or every other day, once we're kind of reaching your goals. So I would certainly increase the frequency to closer to daily.
Great. And speaking of the breathing, we had a few people ask if you could demonstrate the breathing again. I know it's tight in there, but maybe just showing, if you can show like your tummy where your hands were placed, and then just the breathing as well.
Yeah, so you're not going to necessarily see my face, but I'm just going to lower more to my abdomen so you can see my hand placement. So hands are on lower abdomen here. So if our rib cage is here, our diaphragm is right underneath. And when I say 360 breathing, it's breathing so the back, the sides, down into the pelvic floor and into your hands. So the hands are a really good cue to like make sure we're getting this diaphragmatic breath. So you can inhale either through the mouth or through your nose, breathing in into those hands, watching those hands expand, and exhaling, and those hands are just resting back. The abdomen's going back to a normal resting position. You can place the hands on your side if you want to breathe more into your sides to get more of the diaphragmatic breath. And then exhaling, letting those hands just kind of drop as the abdomen and the sides go back to resting position. There's many positions you can do a diaphragmatic breathing exercise on your back. You can do it standing, you can do it sitting, you can do all different types of position to work on expanding that muscle, the diaphragm.
Great. Okay, and I think actually we just have one more question. So can core strengthening exercises help to improve incontinence?
So your pelvic floor and your core are very deeply related. And so if you have a diastasis like that, the pressure system is off. So it's important to not only strengthen your pelvic floor, but strengthen all the muscles around, including your core and your hip muscles.
Yeah, so just think of like the pelvic floor is the bottom of your core. And then you have your abdominals and the glutes and the back muscles. And so we want to make sure that we're strengthening all of those supporting muscles as we're also then strengthening the pelvic floor.
Great. Awesome. Well, we hope today's talk was valuable and that you learned more about incontinence and some treatment methods, as well as some lifestyle modifications to manage and improve your symptoms. If we didn't get to your question today, we will do our best to reach out to you directly afterwards. We will also be sending a handout after the webinar with a recap of important facts, as well as the exercises for you to have a reference. As a reminder, your presenters for today were Marianna DeCaro and Rebecca Arkin. Both are pelvic floor therapists. Feel free to jot down their contact information so you can reach out to them directly with any questions and or to schedule an appointment if you'd like. I'll give you a second to get down their information. All right. And our Q&A moderator was Tom Barsha, physical therapist and clinical director at our West 44th Street office. And I'm Jessie Klein, the pelvic health program director at SPEAR. Feel free to reach out to us as well with any questions, and we'd be happy to facilitate getting you set up with one of our great therapists. At SPEAR, we treat an array of conditions from head to toe, and as a reminder, we're open for in-person visits as well as telehealth sessions. Should you feel that you could benefit from some individualized guidance and treatment, please don't hesitate to reach out to any one of us individually, and we will personally coordinate you being set up with one of our team members for an evaluation. Lastly, SPEAR will be continuing to host webinars through 2021, covering a variety of topics. We look forward to seeing you there. Please follow us on social media and or check your inboxes to learn more about our upcoming topics and the schedule. Thank you all very much for spending time with us today. We hope you enjoyed the webinar and we wish you all the best.